Cohn Solinger from the Center for Global Health. I'm glad to introduce today Dr. David Cohn, who is a professor in the Division of Infectious Diseases and an attending in the Denver Health Infectious Diseases AIDS Clinic. Those of you who looked at the flyer know he has extensive and lengthy experience in a number of different global locations and a special interest in opportunistic infections among HIV-infected patients. And today he'll be talking about his experiences at the University of Zimbabwe as a visiting professor.
Thank you. Which one of these is the pointer for here? Do you know which one that is? Got it here. Yeah. Is any of these a pointer?
There's the underside of the clicker that advances the slides.
Well, if you use this, not a big deal. Okay.
There's also this one.
Oh, this one.
Too many tools.
No, it's
Videos.
Oh, it does.
The trigger. It looks like you got it. If you move your, it's not a laser pointer, but I think it's the arrow.
There's an arrow in the upper left now, but how is he triggering that?
I think if you pull the trigger and move it, you can see it moving around.
You see it up at the top?
Ah, there we go. Okay.
Not the most convenient.
All right, good. Okay, well, thanks for coming today. It's obviously a lot of competition today. The federal government's now closed down for the second day in a row, obviously having a huge effect on our audience. And Dr. Schreier is currently giving medical grand rounds on the cardiorenal syndrome, and I saw the med school. There's introduction to cardiology and wilderness medicine, so a lot of competition. So what I'm going to talk about today is a relatively new program that we have here at the university that's been a very exciting partnership, and I think one that's really going to produce something very important. So I'm going to give a case presentation so we have a proper clinical perspective on what's going on. An overview of the program, its origins, and some of its organizational structure. Talk about Zimbabwe a little bit because we always have to understand the context of a program and what exists there. And Zimbabwe is unique in many ways given its current political structure. Talk about the epidemiology of HIV and TB. I sort of can't give an international talk without doing that, as Charles knows. I am going to share with you some walkthrough rounds that we did at the main teaching hospital there and share with you some of the morbidity that one sees. It's fairly extraordinary. Some other visits I had to a TB and infectious disease hospital, of course, selected travel picks. Can't compete with Charles, but I'll have a couple good ones in there. And then hopefully some time for summary and questions. Some of these slides I'll blow through pretty quickly, and others I won't. So this case presentation is a 35-year-old male who I saw in the KS clinic, along with Dr. Borak, who I'll come back to and introduce in a different way. And he was sent for biopsy and confirmation of suspected diagnosis and how to manage this from a district hospital. And he has had a 4-month history of sores in his left leg and groin, increasing in size and pain, swelling in the scrotum, had a CD4 count of 269, on antiretroviral therapy, which was probably Trivira, which was their most common generic used in Zimbabwe up until recently. He was wheeled into the exam room with this incredibly foul odor. Really, there's some anaerobic infection going on, with wasting of his face and upper body and flies around the bed sheets. So a fairly dramatic presentation to the KS clinic. So I put next slide, please, because if you don't want to look at grotesque pathology, you can close your eyes for a few minutes or leave the room, or if you're like most of us here, you'll get into it in a sort of morbid way. So this is indeed one of the worst cases of KS I've ever seen, and I've seen a fair amount going back to the bad old days. And so what he had was basically very nodular KS, which was necrotic, with fairly characteristic penile and scrotal edema, which one sees quite often, given lymphatic obstruction, which occurs with KS. And not surprisingly, he had brawny edema of his lower extremity, which actually is one of the most common presentations that one sees of Kaposi sarcoma in Zimbabwe. It's really not uncommon. We do see it here from time to time with plaque-like disease, but it seems to be a more common presentation, especially in HIV epidemic KS that's seen there. Not surprisingly, he had an abnormal chest x-ray as well. It's difficult to see on this slide, but he did have bilateral infiltrates, and so the differential was, does he have superimposed tuberculosis, or is it in fact pleuropulmonary capillary sarcoma? And with this extensive degree of KS, it wouldn't be at all surprising if he had pulmonary disease as well. And the only way to sort that out is to go ahead and grab sputa for AFB, and then to treat presumptively. Here, one could, of course, do endoscopy to look for endobronchial KS, but that's not commonly done in peri-hospital. So the diagnosis was obvious to anybody, and therefore Margaret said we don't really need to do a biopsy, and the differential that I mentioned between pulmonary KS or tuberculosis. They were considering admission to support him and to start chemotherapy regimen, and also to treat what was a probable superinfection. When one unroofed some of these necrotic lesions, there was purulent material suggestive of a superinfection, and not surprisingly, there'd be some anaerobic organisms with this being in the groin region. But the matron said, no, we can't do this, who heads the clinic. So he was sent back to his district hospital with a recommendation for debridement, some oral clindamycin to treat a superinfection, some topical metronidazole powder, and icing sugar to decrease the odor. So I learned something. Whenever you go, you learn something new. I'd never heard of that as a homebrew therapy to decrease the odor of anaerobic infections. But when you think about it, sugar kind of makes some sense. And then Margaret did supply him with chemotherapy and instructions as to how to give the doxorubicin and vincristine for his extensive KS. And this is actually the funds for this particular drug supply from the ZATA project, which is the Zimbabwe AIDS Treatment Action Program, started by Jane Oppenheim here at the university. Jane used to be Dr. Schreier's administrator in the Department of Medicine here, got actively involved in this program, now semi-retired. In fact, we have a fundraiser every year. There's a fundraiser in Boulder coming up at the end of the month. If anybody wants information, I can send it to you, and you may want to distribute it. We usually have the fundraiser down here. But what it supports is antiretroviral therapy programs for people in Zimbabwe that are not supported through other resources. So at the end of all this, the pharmacy student who was there, we were literally all gagging. I'm not kidding. That's how foul the odor was. He just turns to me and goes, why did he wait so long? Which is, again, it's sort of a very telling point, but again, one that we've all seen and know about in terms of healthcare-seeking behavior and what brings people to the hospital and so forth. It's not a novel or strange idea, including the 25-year-old kid I saw in clinic 2 weeks ago who's Dan Reardon's taking care of, used to be at Children's, diagnosed at age 17, not taking his meds, and now he shows up in our clinic with 23 CD4 cells, and I think he probably has CMV colitis, and he's getting an endoscopy tomorrow. What's wrong with this kid? And on and on. So what is the MEPI program? It's the Medical Education Partnership Initiative, which is funded through the Fogarty Center. It actually is one of Eric Goosby's babies. For those of you who don't know, Eric Goosby is a well-known HIV clinician researcher who heads up the PEPFAR program with great intelligence and vision. And it's for institutions specifically in sub-Saharan Africa who have PEPFAR support and have partners, mostly United States medical schools. And this is to develop and expand models of medical education. But this is specifically for physicians. There's a separate NEPI program, NEPI, which has been designed for nurses, importantly, but this is for physician manpower specifically. And then it has several PEPFAR goals, which are of no surprise to most people in this room, and most of the PEPFAR sites are in sub-Saharan Africa. And then in addition to those things that relate specifically to HIV/AIDS are so-called linked awards, where one could expand their applications to other areas outside of HIV to enhance clinical expertise, medical education, medical research, and so on. And indeed, Tom Campbell, who wrote most of the grant along with James Hakim from Zimbabwe, was able to get 2 linked awards. In fact, it's the only MEPI program. There are several medical schools who are partnered with medical schools and universities in Zimbabwe. And because of the University of Colorado's prior relationship with Zimbabwe, basically established by Chip Schooley many years ago when he was division chief, one of our fellows, Lisa Fitzpatrick, went over there to do some KS research. Tom subsequently did the same thing, and for those of you who were here last year, Tom gave an elegant presentation on KS in Africa, one of his main areas of research, and he does it specifically in Zimbabwe. So there were prior partnerships, as well as Stanford had a prior partnership. So University of Colorado, University of Stanford, and University of Zimbabwe went together, along with the University College of London, to come up with these three programs. So in addition to the main program, NECTAR, which stands for Novel Education, Clinical Trainees, and Research Program, there is the CHRIS program, which is edited by Ed Havernack, who's a cardiologist at Denver Health, and then the IMHRS program, which deals specifically with mental health. And for those of you, most of you who've been to Africa, you know that mental health doesn't exist in Africa per se, psychiatry, psychology, and so forth. It's basically a nascent practice. So, but obviously an important area. So we have the good fortune of having two linked awards. I'm not going to be specifically focusing on them. I'm going to really hone in on the NECTAR program, and within the NECTAR program, the Visiting Professor program, with a few other comments about other aspects of the program. So what is the problem in Zimbabwe? Well, because of the economic crisis and the dictatorship that exists there, that's really been there for quite some time. As a result, there's just been this incredible brain drain. So that there has been a decrease in medical school faculty, where 39% of faculty positions were filled in 2010. Think about that for a moment. And then the med student enrollment, because of the lack of faculty and other lack of other resources, plummeted to less than 49%. And if one looks at the government practices, where a lot of medical care is carried in district hospitals and other places outside the main areas, such as Harare, 33% of government practices were filled. No docs were 45%. And when I had lunch with Charles Sandy, who's the head of TB, during my first visit there, and I talked to him and I asked him about turnover in district hospitals, and he said it was 40% per year of physicians. So physicians get trained and they leave. They go to Zambia, they'll go to South Africa, they'll go someplace, any place but Zimbabwe, and this is clearly a trend that needs to be reversed. And then really importantly, and specifically for us who are internists, only 19% of their internal medicine slots were filled. So this is huge. So turning this around is obviously very important, but you got to start somewhere. So the structure of the MEPI strategy is basically shown here. Train more doctors, improving the curriculum, and many of us have been involved in curriculum development. Update technology, a lot of IT stuff, and Stanford has really provided most of that. And improve the faculty teaching skills, and most of this is done through the faculty development program, which I'll also just talk about a little bit. Obviously, training and retaining physicians to stick around. Can there be financial incentives? Can there be other reasons for people to hang around Zimbabwe? Most people want to stay in Zimbabwe if they could, but they've been forced to leave for economic reasons. But there hopefully can be other incentives as things change and improve to make good things happen. Community-based learning is really essential. Right now we're focused on Harare, but you really have to expand to other places, and actually we're on the cusp of doing that. We're not quite there yet. And then, of course, encouraging research, because this is an academic medical center, is relatively important, because I think those of us who've been in academic medicine understand that in addition to taking care of patients, teaching and research are fun things to do. And at least to me, in the AIDS epidemic, I think part of the reason I didn't go crazy in the early days of the AIDS epidemic, taking care of people who were all going to die and eventually did, was to really get engaged in research as, I don't know if it's a displacement activity, but an intellectual stimulation that sort of drove me in a direction that I was able to maintain my psyche for what was otherwise really tragic. And I think that has carried over to in many other ways. And so obviously, when you're starting with such a small number of physicians to begin with, to add research into the mix, is an additional challenge to be sure. This is an org chart from the original grant proposal. A lot of things have changed, but you can see there are multiple components that really want to focus on the medical students, on a clinical scholars program, on a research scholars program, a faculty development program, and the visiting professors program. And I'm really going to touch upon this, since that's been my main activity, and mostly talk about that, but share some other components of the program along. And parenthetically, Susan Brandenburg, who is the head of the house staff program here, is in charge of this program on the UC side, and Joseph Matenga is in charge of this program on the UZIM side. And so parenthetically, Dr. Matenga is the head of cardiology there, the preeminent cardiologist in the country. So when President Mugabe gets chest pain, since he has a cardiac condition, where does he go for his medical care? Anybody know? Take a guess. Lisa? South Africa. That's what I would have thought. Nope. He flies to Singapore. And guess who has to get on the plane to go with President Mugabe when he goes there to see all these other cardiologists in Singapore? Dr. Matenga has to drop whatever he's doing, a very busy guy, and hold Mugabe's hand when he flies off to Singapore. That's confidential information. Don't tell anybody else, but I heard it along the way. So, ridiculous. So, what's the Visiting Professor and Lectures program all about? The idea is to collaborate for our faculty and Stanford faculty to collaborate with ZIM faculty and teaching, mentoring, curriculum development, implementation, and to enhance patient care in Zimbabwe. There are a core of several of us who've been involved in multiple different disciplines, who've been over there. And the other component of this is when we go over there to decontest the teaching burden. So if we're running around on the wards and doing some teaching, then maybe it'll free up ZIM faculty to go to a faculty development seminar or something like that. We probably haven't done too much of that, but that was part of the original intent. Certainly to develop relationships that go back and forth across the Atlantic, and that actually is evolving very nicely. So we just sent our first internal medicine resident, one of our chief residents, who happened to be over there on my last visit a few months ago in May. It's taken a while to get off the ground, a lot of bureaucratic nonsense with the University of Colorado and Zimbabwe and the bureaucracies and all that. But very bright, motivated chief medical resident went over there. And we've set the stage for other internal medicine residents who are interested in international medicine to go over there and do rotations. By the same token, we've had several of the ZIM folks over here, project administrators, and the cardiology program working with Chris. We've had a few of the MEDs, who are the sort of internal medicine residents, who will be the future academicians, have come over here to cardiology, and they're not going back, and they're going to set up a slightly better CCU than the one I'm showing you. At the same time, there's a number of folks, cardiologists, who are training every aspect of cardiovascular medicine, which is huge, as I'll show you when we talk about some of the clinical aspects at the hospitals there. And then ultimately, we got to get out of there. We have to do the technology transfer and do the training and let Zimbabwe do its thing. I'd say we're a little behind schedule because we're really in the fourth year of this program now, and that transfer has not taken place. So, for example, the last time I went over there, my main efforts are teaching around TB and TB HIV to the MEDs and the medical students, as I'll show you. And Suzanne Brandenburg said the last time I was going over, so who are you going to turn this over to? And I said, I don't know. And so, I've got to find the TB champion, the junior faculty, who's going to take this on and say, here's the talks, or you do your own talk, or the next time, you give the talk and I'll be there and we'll do it together. I mean, that's what the next time I go over I hope to be doing, which is to move this along. And all of us have to do this as well. So what did I do? I've been over there twice now for 2-3 week stints, and may go more frequently depending upon what else occurs. So I worked with Jake Ray on developing a TB curriculum embedded within an HIV curriculum. Jake was one of our former ID fellows who spent his first year after graduation being paid out of the Department of Medicine to really be our coordinator on the ground. And it was incredibly important that we had a presence there on a daily basis at a physician level to really facilitate the beginning of this program. And so the original agreement was with Tom, after I sort of semi-retired from my job at Denver Health, said, well, I've got time to do this now and plenty of experience in developing countries. Why don't I go over, and I'll go over with Jake and sort of get Jake up and running, because he hadn't spent some time. And to make a long story short, Jake had to get there, and I said, I'm not coming over right away. You've got to establish yourself. You've got to be the man, which then occurred. And so he went over in August. I went over in November, and I was the guinea pig. I was the first visiting professor to go over there, teaching about the thing that's probably the most important topic, or at least one of the most prevalent topics. And then many others have followed and gone from there. So I gave a whole bunch of talks, as shown here, some ad hoc stuff. So like one day Margaret comes up to me and says, listen, we need a tutorial on to teach pulmonary exam. We got some third-year medical students. Can you just go to the bedside and teach them? I go, sure. No preparation. What's the patient? He says, it'll be obvious to you right away. So, and actually I had seen the guy on rounds a few days before, and he had a massive pleural effusion. And so there were 7 medical students, third-year medical students, who are sitting there frozen. They don't say a word. You're at the bedside, so you're tapping away, and the patient, was really pretty good. He got fatigued after about 4 of the medical students, so we had to stop after that. But, just stuff like that. And there's so many things like that can and need to be done. Made ward rounds with Jake and Margaret. Went to the KS and the medicine clinics. I'll share some of that stuff with you. Went to a couple of infectious disease hospitals. And my reason for doing that was my goal was to also set up a TB rotation for the MEDs. And so in order to do that, I had to lobby with some of the faculty. And at the same time, I had to find out what was going on in the country. And because of my WHO experience, I can sort of chat up the guys from the Ministry of Health, knowing how, like in many places of the world, the ministry doesn't really talk to academia and so on and so forth. And I sort of have a little bit of experience bridging those gaps. And I certainly needed the input of the city and the country TB control programs if I was going to set up a rotation in their hospitals outside the med school for a TB rotation, which then fell apart for other reasons. But that was part of my goal when I went over there. And then I also met with Peter Kilmarks, who's I actually met once before, and he's a friend of a friend, and I met with him because obviously the PEPFAR money is going through CDC. The United States government doesn't send money directly to Zimbabwe for some obvious reasons, and so it goes to CDC, and met with Peter, and he's very supportive of the program. But the same kind of thing, as you know, in so many of these places, there's so many players involved, and you really want to get some of this stuff coordinated so that collaboration can take place. One of sort of my big bugaboos. Just one word about the faculty development workshop. It won't be the focus of my talk, but here's Golden Fauna, one of the MEDs who's now junior faculty, training in cardiology with Jake Gray, the person I mentioned. Suzanne Brandenburg, head of our house staff training program. Eva Avgard, who's a world-class educator in our medical school now a vice chair, involved in many aspects of formal education and education, something most of us don't learn about, but now there's opportunities to do so within our own medical school. And then several of the folks who went. And so there have been several faculty development courses, and the whole idea here is to engage the faculty, get them out of their clinics, take them away from the hospital, sit them down for these 3- and 4-day courses, which are really very didactic in how does one teach, and how does one teach specifically in Zimbabwe, and that's an ongoing plan. One needs to get away from time to time. You can't just work. So our first weekend we went down to the Great Zimbabwe, which is in south central Zim. It's a great place, and this is an old city, and there's some ruins which are fairly well intact, which were all developed, I think, in the 13th or 14th century with these incredible brick structures, and it's a UNESCO World Heritage Site. So what's the gig on Zimbabwe? As most of you know, it was formerly known as Southern Rhodesia, Zambia being Northern Rhodesia. Population 12.5 million. It used to be larger, but a lot of people have fled the country and are just hanging out in places like South Africa. Life expectancy went from 61 years to 37 years as the AIDS epidemic started to burgeon and economic problems occurred. Crew death rate skyrocketed from 6 per thousand to 17, and infant mortality rate doubled. HIV prevalence peaked 27% in 97 and now is down to 14% for different reasons, some of which I'll share with you. The gross national income, a whopping $170, with expenditure on healthcare per capita $56, which, by the way, isn't bad compared to other countries in East Africa and Central Africa. The exodus of doctors and so forth, I've already showed you those data. Of note, Zimbabwe claims the highest literacy rate in all of Africa. 90%. And I asked around that, and that appears to be the case. It's not just a false claim, which is relevant to some of the stuff we're trying to do. The economy has been in tatters with rampant inflation, which I'll go over with you in some detail, critical food and fuel shortages, endemic poverty, unemployment, political strife and oppression. Horrible situation over the last 20 to 30 years. Was a major tobacco producer, put that to the side, but made bucks for the country, and really was a potential breadbasket for surrounding countries. Incredible farms developed with a strong agricultural economy that exported and provided for the region and exported to other parts of the world. And then there was a downward spiral, and one of the big events was when Mugabe and other people just sort of kicked out the 4,000 white farmers, many of whom had established families there for centuries, had come from different parts of the world, and basically said, you're out, we're just taking over your land. And the problem that's occurred is, although one could argue, well, maybe that's what should have happened in terms of a black revolution, but the problem is that the structure and the income and the way this has been divvied up has led to a huge loss of productivity. And then sadly, 60% of Zimbabwe's wildlife has gone the way. In fact, I just read 2 days ago that in western Zimbabwe, 90 elephants or something were found poisoned by cyanide because they're trying to poach for ivory. I mean, it's just horrible. So, what's the problem? Well, needless to say, the biggest problem is the president, and is often, again, not unique to Zimbabwe in terms of African dictators and how they hang on to power, and the corruption and strife that goes along with that. So, sadly, but not surprisingly, Mugabe was reelected in August at age 89. And by way of comparison, Jimmy Carter was 89 2 days ago. And since his tenure, there have been five United States presidents who've done 9 terms in that same period of time that Mugabe has remained in power up to age 89. And he's basically going to be there until he's age 94. So this is his last one, his last term, supposedly. Yeah.
So I know that there was kind of a opposition leader was kind of co-opted into this vice presidential position. Is he in line at all?
Right. So Tsvangirai has run against Mugabe twice, and he actually won the election 5 years ago. But somehow they turned it around and said, you're not going to do it. And so he just said, screw it. He pulled out. But to establish a coalition, Mugabe became the state president, and Tsvangirai became the prime minister, whatever that is. And so they're the two leaders, and they sort of get along, or they have to get along. And talking to James Hakeem about this last year, I said, and who's the PI, our close colleague over there, I said, so what do you think is going to happen? He says, they're going to get along. They have to get along. Mugabe's no dummy. I mean, he may be a tyrant, but he's not a dummy. And they've got to work together and get along, and they don't want to see what happened in Kenya repeated all over again with the civil strife that occurred there a few years ago, which was more tribal than anything else than political. And so it's the same deal. And if you go right near the hospital, the grounds, Mugabe's got this ridiculous mansion behind, a big fence, and you're not allowed to take pictures there, and they've got some guy with a Tommy gun in front. And then not more than a mile away or 2 miles away, another nice part of town, that's where Tsvangirai hangs out as sort of the prime minister. And he's being co-opted too, at least, I read some article or heard about NPR or something, where, his henchmen now are all driving Mercedes and they're getting paid bakshish and all this kind of stuff. So it's kind of endless. But that said, things are still happening in a good way, which I'll come back to. So one of the most ridiculous things, and to me sort of hilarious, is hyperinflation, as sort of described on this slide. It sort of, and just by way of comparison, I went to Victoria Falls in 2002. I went with the mayor's task force. Mayor Webb had a business plan which he went. So we visited Namibia, South Africa, and Botswana, and I was tag along and asked to go at the last minute as sort of the AIDS TB expert. So I was there, and we were in Joburg for a long weekend, so I just flipped up to Victoria Falls, not having been there. And that was in 2002, and so when I hit the streets there, $1 US at that time on the regular market was 10 Zim dollars, and if you just went to any kid on the street, you could get 40. So at that time, 40 Zim dollars for $1 US. And then in a relatively short period of time, these tens became thousands and tens thousands and millions and then billions. So that they kept changing the things. So, you know, like here in 3 days, the finance minister said, they're more stable currencies, they could be used, but 3 days later, we're going to add 12 zeros to these bills. And then they said, well, no, after that, we've got to shrink it down and we can't do it. And so I carry this around in my wallet, and I really do have one of these things. Every once in a while, I try and buy something at King Soopers with Zim dollars. It doesn't work very well. So by 2011, Zim dollars were gone, and now you spend US dollars, and South African Rand are currently Zim's currency. So you can play lots of TV games when you're over there. This is a $50 million bill, which one can get. Or you can be a billionaire. Or you want to go to the top, there's a bill for $100 trillion. And I have all these, if anybody wants to borrow some money, you actually look at this. And the question is, are they currently worth anything? And the answer is no, they're not worth anything. And this is a typical $1 or $2 bill that you get in change when you go to the grocery store. They're these filthy US dollars that are just, you know, covered with dirt and grease and everything else you can imagine that just keep getting recirculated. And you see more $2 bills in Zimbabwe than any other place because we never use them here. So somehow these old bills end up over there, and they just kept getting moved around. So, but it doesn't count anymore. One can go around town, and despite all this, you see happy people all over the place. And this is the Avondale Market, which is not too far from where the medical school is in Harare. So looking at the epidemiology a little bit, this will come as no surprise. Main cause of death in Zimbabwe in a study done in 2008. Again, not too different than most other countries in sub-Saharan Africa, where acute respiratory infections, other viral diseases are major causes of mortality. And then not surprisingly, on a population basis, pulmonary TB and HIV-related AIDS, and this includes HIV-related TB. The information on HIV is shown here in Zimbabwe, again with a larger population in 2001 than 2009, an HIV prevalence in sexually active adults of 23%, not too different than many other places in Africa. Now, fortunately, down to 14%, but that's still pretty high. Again, by way of comparison, in the United States, it's less than 1%. Women who are greater than 15 years old living with HIV are shown here, so that's decreased. But kids remain about the same. AIDS-related deaths, like most places in Africa, are finally going down. Unfortunately, you end up with many more orphans because adults die and kids survive. And again, this is not unique to Zimbabwe. If one looks at a study that was done in Bulawayo and Harare, a nice study looking at longitudinal data, they got some superb surveillance data to look at there. One can see the relative proportion of HIV-related mortality that it's played out during this period of time where it just skyrocketed as HIV was introduced into the country. However, like every other place, antiretroviral therapy is making a difference. Again, the most common combination is Triviro, which is 3-TC, D4T, and nevirapine. But given the known toxicities, cases of lactic acidosis, which have occurred, lipodystrophy, and so forth, tenofovir is moving in. And now the current recommendation are now tenofovir-containing regimens. And so they have a triple-like regimens, combination pills, which are now first-line therapy, as it is, again, in most places. Have we met goals yet in terms of giving antiretroviral therapy? No, not yet, not even close. But at least you got to start somewhere. And so if one looks at the prior WHO guidelines of starting people with full-blown AIDS or CD4 less than 200, you can see that about 49% of the people who were at risk actually had initiated ART. If we look at more recent guidelines, it's only a third of individuals. Pregnant women, not high enough, 56% who are on ART to prevent MTCTP. And pregnant women tested for HIV, an enormous presence of 46%. This is just like Botswana, South Africa, so many other places. And then of infants born to HIV positive mothers, only a third have gotten on so far. But I think all of these things will improve as more PEPFAR money is there. Because again, PEPFAR started later there because it was Zimbabwe as opposed to some of the other high-focus countries that were originally funded through PEPFAR. And there's starting to be some good news. So this is an EPI curve that we've seen in many parts of the world. HIV is introduced into a country. The death rates skyrocket related to untreated HIV in patients who are clearly at risk with lots of other comorbidities than we ever see here. But I think things are starting to turn around now with ART being introduced in 2004. And there'll be more longitudinal data, which hopefully will continue to show trends in the right direction. So let's shift gears a little bit and talk about Perry. Perry and Wad, I don't know how to pronounce it, so we just call it Perry Hospital. And this is the main teaching hospital, akin to the University Hospital here. Huge complex with incredibly long corridors. So the last time I was there, I tried to pace out the corridors going from Ward C1 to Ward C8, and it's something like a mile. You know, the sisters were looking, the sisters are nurses, they're looking at me like, what is wrong with this guy? I'm going like this, trying to do paces like yard by yard to figure out how long this hospital is. So, and they're insanely long. So in one of the corridors near C8, which is the main NECTAR teaching ward, this is again Jake Ray, our junior faculty now in practice in Alaska, and doing a lot of TB work, by the way, at the Public Health Service Hospital there. So Jake's now seeing more TB than any of the rest of us combined, just as he did in Zimbabwe for a year and a half. And Tendai, who was one of the first MMeds who was going to graduate from the program. So again, you've got medical students who then become JRMOs, which are junior residents, who then become SRMOs. Then people have to go out in the field and do a mandatory primary care rotation. And then if you want to be involved in teaching or become part of the faculty, you then become part of the selective MMed program, which is essentially the equivalent of a 3-year internal medicine residency, which also requires, in addition to lots of training, dissertation as well. So teaching rounds at the hospital are very typical for what one is used to here. This is Jake with his team. And the stuff you see there is just over the top, not surprising. So HIV, this is just stuff I saw in 3 weeks of rounding on the hospital. Saw every one of these complications, and some of them a lot of cryptococcal meningitis they got coming out of their ears there. And all the other stuff that one would expect to see. Obviously, TB being the most common opportunistic infection, although I got to tell you, I think I saw just as much crypto walking along the wards as we did suspected tuberculosis. And then tons of other stuff, with or without HIV, a tremendous amount of cardiovascular disease, renal disease, diabetes, you name it. And just incredible stuff that it's just I don't have time to really describe, but everything under the sun, as one would expect in a developing country or in Africa in particular. So I'm just going to share with you a few of the cases I saw of the many. This was a guy that came in with a weight loss and went from mental status to becoming comatose. The guy had a potassium of 9. Think about that, 9. With a creatinine of 12, and his diagnosis was newly diagnosed HIV nephropathy. And with just little old peritoneal dialysis, which is how they do it there. They don't have a hemodialysis center. This guy woke up, survived, and here's the JRMO, who's one happy dude who spent many days and nights taking care of this guy. And now he's on antiretroviral therapy. I suspect he'll do quite well. I don't know how much of his renal failure will recover, is often the case with HIV nephropathy. There's presumed diagnosis. This isn't biopsy, but he's got HIV, no renal failure, nothing else going on. That's probably the diagnosis. Here's a patient who been previously on antiretroviral therapy and had been switched to a non-containing regimen, had a history of prior TB. So he comes in now with some new neurologic syndrome and new wasting. Nobody was quite clear what was going on. His family couldn't afford to pay for a CT scan, so we're kind of shooting in the dark. And we just started him on a retreatment regimen for TB, not really knowing what he had, which is often the case there. And then I showed this picture because he had, this lesion. I tried to ask him through Shona, through an interpreter there, as to why this occurred. And you do see a lot of this in different parts of Africa where through some other faith healer or local medicine man, one sees a lot of different skin lesions from cupping and trying to get out evil humors and stuff like this. It's not unique. This is a patient who presented with seizures and had cryptococcal meningitis on the floor as a seizure precaution. There was a fluconazole study going on at the time I was there, but amphotericin is also given, but not liposomal amphotericin. This was a lady who had known HIV, comes in with a new left nodular infiltrate, which is not easy to see on this burnt out chest film. Most of the x-rays I took, you're just kind of there holding up to the light and taking your cell phone and trying to take a picture or stuff like that. So it's not quite as elegant as the packs that we have at Denver Health or whatever they have here these days. She was smear negative. We assumed she had TB and gave her cotrimoxazole and anti-TB drugs. This is the standard. And then she'll get started on antiretroviral therapy after she's referred to an OI clinic. This was another amazing case. A 25-year-old came in with this humongous mass on x-ray, had some big lymph nodes as well, had an LDH of greater than 4,000, HIV negative ×2, and he has a lymphoma, which I don't know if it was EB related or not. Probably was, but not all lymphoma is. But as you may recall, Epstein-Barr virus-related lymphoma was first described by Dennis Burkitt in Africa about 50 years ago. Tons of rheumatic heart disease. Again, we hardly see any of it there. There's lots of it around. And this is a 44-year-old guy who had a relatively large heart on x-ray. He also has a contiguous pneumonia with only AI, mitral gurge, pulmonary systolic with pulmonary hypertension. And at the time I was there, Brian from this institution was just teaching 3 technicians how to do ultrasound to be able to do echocardiography there, which is now, when I went back the second time, it's being done fairly routinely as the other young cardiologists are being trained. So it's very helpful, obviously, to have echocardiography, especially when you've got all this incredible valvular disease. As I mentioned, cardiovascular disease is unbelievably common. Every once in a while, you can get a CT scan, and so you just see lots of people coming in with all sorts of CNS syndromes, but stroke is huge. So I think actually of the 3 different programs we're doing, in addition to NECTAR and IMHRS, I think Chris is a home run because there's so much cardiovascular disease. It's just there's so much that needs to be done there, and so to have this teaching program and develop a research program within it with these young budding cardiologists with training from our institution is I think fantastic. And then on my last trip there, this was kind of a shocker. So this was a lady who was diagnosed with pellagra, of course, never having seen it. I don't think she had dementia, but she did have some diarrhea. She had a history of carbohydrate intake only. I had several other pictures, but to try and keep it simple. So these are fairly classic desquamating lesions that one sees. And this is the Casal necklace. Dr. Casal first described this a few centuries ago, and this is fairly characteristic, where one gets this denuding around the neck with a sort of hyperkeratotic lesion. And so this is sort of pathognomonic for pellagra, which I learned, of course, only reading about it after the fact. They do have a fundamental CCU there. This was a lady who was unbelievably sick. Again, sort of a large heart on x-ray. All she had on her echo was mitral stenosis, mitral and tricuspid regurgitation. I'm sitting there listening to all these murmurs while these machines are going off. It's kind of like, I was a medical student again, trying to learn all these murmurs, that most of which I hadn't heard in a long time. So she, again, was in septic. She was in cardiogenic shock. Was just a mess in a dress. Then got digitoxic and hypernatremic, and she walked out of the hospital. It was just incredible care, just amazing. So, but needs cardiovascular surgery. Can't be done there. Has to go to South Africa to have that done. They're trying to work on that partnership, and I think as the cardiology firmament gets bigger and better, there'll probably be more of that as time goes on. And it won't surprise me if they eventually end up with cardiovascular surgery in Harare, but it's going to take a while. There's a MICU there as well, relatively small. Organophosphate poison is actually quite common. And this was an unfortunate 14-year-old man who didn't make it. And I show this picture just to show the nursing station and the plan, a little different than our, they don't quite have a electronic medical record yet, although there is one in the OI clinic. And I kind of like this one, consult general surgery here and chest fluids, and then this was on the cover of the MAR there. So it's We Treat and God Heals, bed number 1, which is what this patient was in. Like I said, he didn't make it. Again, down by the integrated Zimbabwe, should you chose to go there, there's a nice game reserve that's relatively close by with just a beautiful hotel down there that costs us like $35 a night or something. This is Brian, who's now at University of Nebraska, heading up their CHF program. Lisa, who's a PhD candidate at UCSF, who's working on an MDR-TB project. And then Jake, who's now in Alaska. And a couple other animals who are just kind of hanging out, checking us out. The KS clinic on Thursday mornings is ridiculous. So it's run by Margaret Borak, who's got to be one of the 3 greatest physician saints in the world. I just think it's unbelievable. She's chairman of medicine there. She's, again, been collaborative with KS Research with our institution for many years. She's just this intense, caring physician, a great teacher, got all this stuff going on, and uniquely is one of the few people in the Department of Medicine who's full-time. Most of the faculty, like in other parts of the world, they do their faculty stuff in the morning or afternoons, and they have a private practice in the afternoons or evenings to be able to pay the rent. Margaret is not. She is full-time, and therefore an incredible asset to the program. Here's Jake hanging around in the hallways, and not just KS, and this sign changes to nephrology clinic or neurosurgery clinic or whatever, the next day. I love the names. So Justice was a pharmacy student, and Johnson and Warning were third-year medical students who were rotating in the clinic. And so I was having kind of fun with them. I said, does anybody here know where the name Kaposi's comes from? Damn, they didn't know. So I told them my great-uncle, Moritz Cohn, who changed his name to Kapos, in 1852 when he first described Kaposi sarcoma. By the way, he spelled his name C-O-H-E-N, not C-O-H-N. So anyway. But the stuff you see there is like ridiculous. Again, this was a 29-year-old guy who came in, CD4 197, had been treated, and we think he probably had immune reconstitution syndrome, actually, because his lesions got worse with his lesions on his nose, his gingival lesion on his tongue. He had a lesion on his toe. And once again, get an x-ray, bam. Got some lung nodules, and we went ahead and got a smear. I think Margaret started him on TB medication. And again, the only way you know it was KS would be to do an endoscopy, which we didn't do. This case really struck me, which is why I'm showing it. 15-year-old orphan, still alive through perinatal transmission. He's diagnosed when he was 9 years old, but couldn't have acquired it any other way. So he survived till he was 9 with really no intervention, amazingly. KS diagnosis when he was 13. He's got some residual right leg edema, and like so many adolescents, kind of fell out of care. So he's back in the clinic on the day I saw him, smiling with a CD4 cell count of 3. And he'd been through several rounds of chemo, and so he needed to get back on antiretroviral therapy. Margaret told me the youngest kid with KS she'd seen is 5 years old, with Kaposi sarcoma and a 5-year-old. One of the complexes around town is a government facility, the city facility, the Wilkins Hospital Clinic Complex, sort of like Denver Health would be. It's got an STD clinic, the so-called dermatology of venereology, urinary, and they have a TB clinic. So I visited the MDR TB clinic there, both because I'm heading up this TB research working group, so wanted to learn more of the lay of the land to sort of know what's there in terms of the facilities. As I'll show you, they don't have a boatload of MDR TB yet, but this clinic covers one half the country for referral, and they were taking care of about 35 patients at the time with documented MDR TB, patients who had treated with a retreatment regimen and then ultimately had cultures done, and which is not the standard of care, and were shown to have drug-resistant tuberculosis on a relatively standard regimen. And you can see it's a fairly tough to see, but fairly typical X-ray for tuberculosis. I then also visited the Beatrice Road Infectious Disease Hospital, and again, the idea was I was hoping to set up this TB rotation. So these are run by city docs, basically, And so this is a big campus outside, sort of on the outskirts of the city. And they were, in fact, doing remodeling to set up a TB isolation ward for people with known MDR or XDR TB. I don't think XDR has been documented in the country yet. And they were doing the same thing in Kenya when I was there a few years ago at Kenyatta Hospital, retrofitting a separate TB ward to actually have a true isolation facility where you've got room air changes and so forth, so you could do some meaningful infection control for TB, which is otherwise non-existent in Africa. MEPI of TB is shown here. Again, a population of about 13 million, an incidence of only 600 cases per 100,000. By way of contrast, in Colorado, it's 3 per 100,000. In Cape Town, which has the highest rate of TB in the world, it's 1,000 per 100,000. So it's pretty high still in Zimbabwe. Fortunately, the incidence starting to see a decrease in the incidence. A lot of prevalent cases. Unfortunately, there's still mortality, which shouldn't exist because we can treat TB. A good HIV testing program. WHO has really emphasized HIV testing through its TB HIV collaborative initiatives, and so now a lot of patients are tested, and 60% are in fact found to be seropositive, very similar to other places in Africa, and a relatively low rate of MDR-TB in new cases. And like all other countries, when you take patients who had prior treatment, they have higher rates of MDR-TB, not surprisingly, but these are not as high as places like South Africa and many other places. And in large part, MDR-TB is not that common in Africa yet, because remember, rifampin wasn't introduced into Africa, with the exception of South Africa and Botswana, until about 10 years ago. When I was working at WHO in 94, 95, people were still using INH and thiacetazone in most African countries to treat tuberculosis, not rifampin. In initial phases, yes, but not in the continuation phase. And from the WHO, one can see rates of TB in Africa and HIV-related TB. Again, trends now heading in the right direction. And in Zimbabwe, and look at the differences in scale. This is 400, this is 1,000. One sees Zimbabwe, all TB, HIV-related TB, but trends going in the right direction. And importantly, lots of patients with TB are getting put on cotrimoxazole and antiretroviral therapy. This is an artifact. This is not correct, but as you can see, the trends are heading in the right direction, but less than stellar. The other part of this infectious disease hospital wasn't just a new TB ward. This is where they deal with epidemics. And at the very time I was there was a typhoid epidemic. So there was the TB side I showed you before, and then you walk, and there's this fork in the road, and it's the fever side. And so this is a facility, as I mentioned, there was a typhoid epidemic that was occurring at the time. And when I met with Dalen Mugafa, who was basically the disease control director, kind of like what I used to do for Denver, we had a nice chat, and I was really chatting about TB and could I visit the hospital and so forth. But then, I said, I heard on the radio this morning there's typhoid. What's going on? So I kind of, switched my other hat and communicable disease hat, and we talked about that for a while, and that was kind of fun. So here you go. You walk into a room, and she's got fever on her pillow. So to me, she's the poster child for infectious disease docs. In fact, she was a young lady who was suspected to have typhoid. And as part of their workup, they're getting blood urine cultures for typhoid and treating everybody who had a syndrome empirically with ciprofloxacin. And I don't know if she ruled it or not. She wasn't particularly sick, because most people with typhoid are usually pretty sick, but she was doing okay. But I think we really need to have pillows marked with fever at Denver Health and here and other hospitals you work at. Charles, you need to set this up in Boulder Community. So what are we doing? What have we done? Just to wrap it up. So we've done a lot so far. So from the visiting professor program itself, there have now been 66 individual faculty from many partner institutions, mostly here at Stanford, but UCL and a few other places as well, doing a number of different tasks. Conducted 15 workshops. Most of these are related to the faculty development workshops, but other stuff like some seminars I gave, for example, with lots of time doing didactic and bedside teaching. So why would one want to do this? Well, I think I'm speaking to the choir here, but clearly one can observe a broad spectrum of severe illness that we don't see here. The challenge of your diagnostic skills, you're at the bedside. It's like, you're being trained by a UK doc. You don't get CT scans. You don't get this technology. You're not even going to get a urinalysis. You gotta see the patient, examine them, make a diagnosis. Of course, it's important to have and gain cultural competence when you're teaching in a situation like this. But the point is, you've got a very eager group of listeners and learners. It's very gratifying. It's the buzz. That's what I'm in it for. When you see the things going on, it's like when your kid's 18 months old and you're watching they're putting the connections together. When you got a medical student, they're putting the connections together. That's fantastic. And my way of looking at it is, look, this is huge. Every little bit helps. And so a few weeks of teaching and making an impression and sort of guiding someone in the right way is worthwhile. You're not going to change the world in a day. You can participate in other projects. Case Rietmeyer, a colleague of mine, is setting up an STD program or doing an STD research program, looking at the etiology. As I mentioned, Tom asked me to head up a TB research working group, and so I'm trying to do that within the context of the NECTAR program to sort of build up some more stuff that's for Zimbabwe. We want to do the right thing and do it well, and then you actually can hear an S3. When's the last time you heard a third heart sound in a patient? It's ridiculous. So, and then if you're smart, you do some business. So, have we accomplished anything? Well, actually, there's some pretty impressive data. This is not all obviously attributed to MEPI, but as you can see from the slide, things are heading in the right direction. The faculty numbers have increased by 29%. Undergraduate enrollment in the medical school has increased. There are students who are planning to stay in Zimbabwe, or so they have told us in our longitudinal questionnaires. Increase in medical practitioners, and a new student intake, and huge growth in the program in MEDs. So when we started out, there was one MED in the third year program. When I was there last year, I had a room full of 30 MEDs. The year before, I talked to like 11, and so things are improving in terms of the number who are matriculating this program. So just to close about Zimbabwe, because again, you always have to think within the context. One of my favorite movies, Clint Eastwood, Good, Bad, and Ugly. So clearly there's been a downtrodden economy, enormous morbidity, horrible things have been done to the land and the infrastructure. Mugabe's, what can you say? A lot of other corrupt politicians. It isn't just him, it's the other disparities which exist. Mugabe wasn't the first oppressive government in Zimbabwe. He's not the only oppressive government in Africa, resulting in setbacks in health. On the other hand, these are lovely people. You meet the drivers, you talk to patients, whoever you talk to on the streets, very friendly, very engaging, and they just deal with the shit. It just amazes me. It's just incredible. And with a high level of education, there's a lot of promise there. A sound infrastructure. Zimbabwe used to be quite the place, like Kenya used to be quite the place, with potential to rebuild. Programs like NECTAR, which hopefully will restore and improve things. And then, of course, there's a lot of uncertainty. Since we have uncertainty here, we don't have a U.S. government that's open right now. So it's not just Zimbabwe, but there's clearly things that we can't figure out yet. All we can do is work with what we got now and then go from there. So I'll acknowledge lots of individuals who contributed to this talk. Tom is the principal investigator here and acting head of the Division of ID, also engaged in KS research over there. Jake, who I mentioned previously, Suzanne, who's head of the house staff program here, Nancy Manninger, who's head of microbiology here and former head of our training program, was for 20 years, involved in the Mentors Clinical Scholars Program. Eva, who I mentioned before, Ed, who's the PI in the CRIS program, and Susan, who's a project coordinator, and several folks from Zimbabwe as well, most of whom you don't know. So this has turned into a fairly large enterprise with lots of different partners involved, as shown on this particular slide. And I'll stop there and right on time, but I'm happy to address other questions or comments that you might have. Charles.
Well, with your comments about all the cardiovascular disease, is anybody doing any preventive efforts either in your program or even in the country?
You mean in terms of what will preventive efforts be in terms of cardiovascular disease? I think we're just scratching the surface. I think there's so many needs assessments and epi studies that need to be done before you launch into that. I mean, you're seeing, we're seeing the back end of it, obviously. You're seeing the morbidity at the back end. In terms of diet and so on and so forth, there's a pretty big meat industry there, and yet there's also vegetables, and there's no lack of food. So, but sort of the tailor-make dietary thing, I don't think we're even there yet. I think there's just a lot of fundamental epi stuff that's got to get done before you even launch into that kind of a thing, I think.
Related to that, what about acute rheumatic fever?
Well, it's the same. Again, I have to defer to the cardiologist on that. Clearly, you can intervene. I mean, Wyoming used to have the highest rate, and Colorado used to have some of the highest rate of rheumatic fever in the country 60 years ago, something like that. And there's penicillin. It's not difficult to get penicillin around there. So I think there could be proactive screening programs, and I don't know. I actually don't know if the cardiologists have started to scratch the surface on that. But and actually, I'd probably start there before diet, although you can do dual programs at the same time. So again, I think that whatever can and should be done is in its infancy. And again, I don't think it's unique to Zimbabwe. I think this is true in other places as well.
I was just going to ask, with decreasing HIV prevalence and specifically transmission, do you have any sense of what of this is due to mortality, what of this is due to drugs, and what of this is due to behavior change?
I think it's all. I don't think it's hard, it's really hard to tease it out. And again, these are cross-sectional, so our prevalence data. Most of them are not done to longitudinal studies. There has been some excellent research. Frances Cowan, who is the PI at Amherst, she has done some elegant work on HIV and STD prevention in adolescents in Zimbabwe. A lot of published stuff. Her affiliation with UCL, but she's now a Zimbabwean citizen and very focused and a really bright lady. So she has some data which speaks to the issue of HIV prevention programs. There's also a very active circumcision program going on right now. So I think it's all of the above. I'm not going to take the Chip Schooley approach that just give them antiretrovirals, put it in the water, and the epidemic will go away. I just don't think that's correct, because we all know that people just don't always do that. Okay, some of it's, of course, a die-off of your most prevalent population, and just like we saw in the early days, you get this early die-off, and so that's going to affect your prevalence, but then it's offset by an increase in incidence, and so since the incidence is going down, the prevalence is going down. There are behavioral programs. I think this stuff is taught in the schools. And like every other African country, everybody knows about AIDS and HIV. It's a question, what do you do about it? That's my guess. I actually haven't sat down with Frances to ask her that question, but she'd be the person to ask that question, to direct that question to, or others like her.
You mentioned that there has not yet been a recorded case of XDR-TB, but you talked about the MDR ward and the isolation, like the new ventilation system. Can you talk a little bit more about the MDR situation and how that's been progressing?
So you want me to talk more about the MDR-TB situation? Yeah, okay. So I'll start out by saying, first off, except for South Africa and Botswana, there have been a lot of drugs for a long time. MDR-TB is not the problem in Africa that it is in Eastern Europe or Russia or Korea or China or places like that, okay? Just starting out. But it's there. And the question is, how much is there? And the reason is we don't know, because until we started doing drug-resistant surveillance in 1994 and 95 on a global basis, a program which I just happened to be there at the time they got it off the ground. I just kind of lucked into this thing in terms of the origins of it. We didn't really know. I wrote a paper with Mario Viglione and Flavio Bustreo. We reviewed the world's literature that existed on drug-resistant TB and published it in CID in 1996 or something. And basically what our paper said is we don't know anything, is what we said. And so we needed to start a program to really look at it. And if you look at the drug-resistant surveillance surveys from WHO, there have now been 5, or they're on their 5th. Very little of this has been done in Africa, so they didn't have the reference labs to even get the work done. But now they have that, which are called partners with supranational reference laboratories. So the laboratory infrastructure in Zimbabwe is fabulous, okay? They've got Central National Reference Laboratory, BRTI, which is the research institute. They've done a lot of collaborative stuff. Maduri, who's a super tech from Phil Hopewell's group at UCSF, has been on the ground there training, as she's done in Tanzania. So you've got some techs there who've got great names. The head of the research lab at Wilkins, her name is Mona Lisa. She's the head tech there. So, and then another woman at another lab. They all these fabulous names there. So they've got good laboratory support now. And so what you need to do is to find out, you need to do a population-based study. You don't just take the patients who are retreatment patients. In other words, I fail, I had TB, I've got it again. You don't take those numerators to try and figure out what the epi is. What you got to do is a population-based survey. You need to correctly identify, is this a new TB patient or a retreatment patient? And then look at your rates of TB as this evolves. And you've got to do it with an epidemiologic selection so you get from all sectors of the population. That's just getting off the ground there now. So we'll really kind of see the kind of data I showed you. It's estimate data. It's on a WHO website. It may not be very accurate. But on the other hand, you don't see MDR TB coming out of our ears. What will change and is changing the landscape all over Africa is the implementation of expert MTB RIF, which, if you don't know what that is, it's a new diagnostic tool which is able, through molecular biology, on a single sputum specimen, is able to identify within a matter of hours, okay, whether or not that specimen has rifampin resistance, and whether or not, and by inference, then the patient has MDR-TB, because the vast majority of patients who have rifampin resistance have INH resistance. And more importantly, perhaps more importantly, it identifies cases of TB who are smear negative, because 50% of HIV-related TB in Africa is smear negative. So a patient comes in, and you rely on the smear, which is the standard of care for diagnosis, which sucks, you're missing a lot of cases. By using the Gene Expert machine, you're going to diagnose a lot more cases, and at the same time, in real time, diagnose the patient who has MDR-TB. So instead of treating that patient with INH rifampin pZ-anethambutol, which ain't going to work, you're going to start them on a regimen that treats them for presumptive MDR. And at the same time, you can get specimens on those patients, then send them to the reference lab and get susceptibility testing to first and now second-line drugs. So 5 years from now, we're going to have way more data and be much more knowledgeable about the MDR-TB epidemic, not only in Zimbabwe, but in all of Africa, I'd venture to say. And then I'd like to write another review, say, hey, look at this. But you need lots of data input from all over the place.
All right. Thank you.
Thank you very much. Appreciate it.